Hi, everyone. Welcome to the LactFact podcast, which highlights recent clinically relevant research, policy statements, and protocols that you, as a practicing lactation professional, would probably like to know about. I'm your host, Dr. Eglash. I'm a board-certified family physician and breastfeeding and lactation medicine specialist. This podcast is written and produced by the nonprofit organization IABLE, which is the Institute for the Advancement of Breastfeeding and Lactation Education. We have no commercial funders for this podcast series. Hi, everyone. I want to update you on the recently published clinical report by the American Academy of Pediatrics entitled Promoting Human Milk and Breastfeeding for the Very Low Birth Weight Infant. This was published in the journal Pediatrics in February 2026. The lead authors are Margaret Parker, Lisa Stellwagen, Emily Miller, Larry Noble, Mark Corkins, and Mark Hudak. As a high-level summary, the authors state that every family of a very low birth weight infant should receive information about the critical importance of mother's own milk to the health of their infants and receive intensive support throughout the full course of their infant's hospitalization to achieve their personal lactation goals. They also state that provision of pasteurized donor human milk is recommended when mother's own milk is not available, insufficient in volume, or is contraindicated. Pasteurized donor human milk is to be prioritized until the infant's risk of necrotizing enterocolitis is low after 34 to 36 weeks postmenstrual age, and they only recommend preterm formula when mother's own milk is not available and when pasteurized donor human milk is either not available or the family declines the use. So let's dig into a few more details regarding this clinical report. First of note, they have a table that summarizes randomized controlled studies that compare multiple health outcomes among very low birth weight infants fed various combinations of mother's own milk versus preterm formula, and the effect of adding bovine or human milk-derived fortifiers. In their summary of the data, they report that pasteurized donor human milk as a base diet or as a supplement to mother's own milk, when compared to preterm formula, reduces the risk of necrotizing enterocolitis, but does not have the same health benefits as mother's own milk when it comes to late onset sepsis or improvement in neurodevelopment. Unfortunately, they're comparing pasteurized donor human milk to mother's own milk, but they don't discuss pasteurized donor human milk versus preterm formula as a form of supplementation for other issues such as neurodevelopment, retinopathy of prematurity, or chronic lung disease. They looked at the studies that compared bovine versus human milk protein-based fortifiers. So there are two different types of fortifiers. One where the fortifier, the protein, is coming from cows or bovine, and then there are some, mainly from one company, where the protein is derived from human milk. They felt that the studies did not provide enough evidence because in terms of the difference in those fortifiers, in terms of outcomes, because the patients who receive the fortifiers with human milk protein were more likely to have a base diet of breast milk, and the patients who received the fortifiers with bovine protein were more likely to have preterm formula as a substantial portion of their base diet. So they couldn't tell if the differences in health outcomes were related to the base diet or the fortifiers. They then point out that more recent studies that compare a breast milk diet with fortifiers from human milk protein versus moderately hydrolyzed bovine proteins shows no significant difference in necrotizing enterocolitis and no differences in late onset sepsis or death. So this clinical report essentially does not advocate for the use of fortifiers from human milk proteins. There is evidence that mothers of very low birth weight infants are more likely to initiate lactation as compared to mothers of term infants, but many of these mothers do not meet their intended feeding goals because of so many challenges such as comorbid conditions that affect breast health, maternal-infant separation, pump dependence, and just life in general, such as living far from the NICU, going back to work early, caring for other children, etc. But they also state that one factor for lactation difficulties is less time for breast development due to shortened pregnancy. But I want to point out that there's no evidence that this is true, and full glandular development is pretty much reached by 20 to 22 weeks gestation, according to several research studies. Even the reference used in this clinical report states that breast development peaks at 20 weeks. So I don't know why they report this. If health professionals believe this, they might feel compelled to shrug their shoulders in situations of low production, blaming limited breast development due to prematurity as the reason. I'm glad to see that they have a paragraph on the physician's role in supporting lactation for NICU families, which includes counseling on the importance of breastfeeding for maternal-child health and the need for physicians to provide evidence-based patient education on breastfeeding. I wish they had gone further into this to advocate for more physician education in medical schools and residencies. The report discusses the importance of lactation education for families, the need for lactation consultant support, and for staff education so that nurses can provide evidence-based support as well. The report then goes on through some specifics about milk expression, such as when mothers should initiate pumping, the frequency of pumping, and the issue of coming to volume by producing at least 500 ml a day by day 14, because this is associated with longer duration of milk production during the NICU stay. The authors discuss skin to skin, and that is even appropriate for babies who are ventilated on CPAP, and that skin to skin needs to be facilitated by multiple different staff, including respiratory therapists. There's a section on oral immune therapy with colostrum and early transition to direct breastfeeding. I don't love the term transition to direct breastfeeding because that makes it sound like they have to transition from something else like a bottle. They state that mothers can be encouraged to begin oral feeding at the breast as soon as the infant shows physiologic readiness, including feeding cues. The authors recognize that oral feeding at the breast can begin at 31 to 33 weeks, although I know there's evidence of babies nursing at a much earlier age, such as 28 weeks. As an aside, Dr. Raylene Phillips at Loma Linda in California published a study in the last couple of years demonstrating that if the first oral feeds are at the breast, there's a higher likelihood of breastfeeding in the NICU, and I wish they had pointed that out. There's a pretty lengthy section on addressing health inequities in the NICU with a discussion of underlying factors associated with lower breastfeeding rates in minoritized communities. They also have a section on pasteurized donor human milk, including the nuances of using consents that are either opting in or opting out of the use of donor milk and how long to provide donor milk. There's strong support in the statement for fortification of human milk during the NICU stay to support growth and development. In their section on discharge planning, they state that more than half of very low birth weight infants have extrauterine growth failure at the time of discharge. And they define this as the weight for gestational age being less than the 10th percentile. They acknowledge that there's insufficient evidence examining the effect of fortification on growth among breastfed very low birth weight infants after discharge compared to those who are exclusively formula fed. Fortunately, they do not recommend that all very low birth weight infants receive fortification with preterm formula when they leave the hospital. They only recommend this for infants who are at high risk for extrauterine growth failure, but they don't actually go into details on this. This statement is much less specific than the NICU GRAD recommendations from the Academy of Breastfeeding Medicine and from the 2025 European Society for Pediatric Gastroenterology, Hepatology, and Nutrition. The European Society has very clear growth parameters that would indicate the need for fortification, and it's clear that there are many infants who have done well in the NICU with adequate growth who do not need to be fortified at the time of NICU discharge. They have a small section on informal milk sharing and essentially recommend shared decision-making with the family if they're using milk from other individuals. I'm happy to see that they discourage pumping and dumping when there are questions about meds, and they provide evidence-based medication information resources in this document. In their section on complications impacting lactation, they mainly talk about cytomegalovirus, or CMV, and HIV. They reviewed some of the evidence on exposure to CMV via mother's own milk, and they state that even though freezing breast milk can reduce CMV viral exposure, it doesn't completely eliminate the virus, and there's no clinical difference in outcomes in terms of the risk of sepsis-like condition from CMV if they have frozen breast milk or not. That said, they discouraged withholding mother's own milk because of the risk of postnatally acquired CMV. Then about HIV, the American Academy of Pediatrics put out a clinical report in 2024 regarding breastfeeding in the setting of maternal HIV infection, which I recommend people read. The authors refer to that 2024 set of recommendations, but also state that very low birth weight infants have a higher risk of contracting HIV. So they leaned towards feeding babies pasteurized donor human milk rather than mother's own milk, even if the mother's genetic load is undetectable, but then they also state that shared decision-making in this situation is also reasonable. Their final section is on advocacy for families, such as making sure that the special supplemental nutritional program for women, infant, and children, also known as WIC, continues, and they support paid family leave, livable wages, and housing and education support. They advocate for pasteurized donor human milk for all NICUs and state-level legislation to be sure that pasteurized donor human milk will be paid for in the care of very low birth weight infants. They state that the American Academy of Pediatrics continues to be an advocate for passage of federal legislation that would expand funding for milk banks and create a pasteurized donor human milk awareness program at the United States Department of Health and Human Services to educate the public on donor milk, which I think would be amazing. In summary, this American Academy of Pediatrics clinical report is a pretty good resource for NICU quality improvement projects regarding breastfeeding in the NICU, other than a few caveats that I mentioned throughout this piece. Have a good few weeks, and I'll be back in a month with another topic. See ya. Hey everyone, thanks for listening. I encourage you to check out IABLE at lacted.org, which is LACTED.org, to learn more about our educational projects, courses, educational handouts, videos, live conferences, and webinars. By becoming a member, you are not only supporting our free projects, but you will also receive a series of benefits, which you can learn about at our website. I'll be back with another LactFact in a few weeks.